Well, what a difficult two acts to follow. Fortunately, I'm going to be short. I'm just going to speak a little bit about some of the implications of this. Those of you who read almost at all will realize that adolescent development and the adolescent brain, and particularly Jay Geed's work, have been incredibly influential and topical and controversial over the last 10 years. The internet is full of images like this. People, how we build the adolescent brain. So I'll come on to that. So no disclosures? Okay, moving on. So what are the policy contexts? What are the clinical contexts for this? I spoke yesterday about the shift of burden from childhood to adolescence. There is something about modern economic development and modern society that's relatively toxic for young people. And we need to think about whether it's something about the adolescent brain and adolescent behavior that's part of that. And I love that last thing that Jay said, moving parts get broken. And there's something about modern society that seems to be breaking things more. The next bit of concept, public health concerns. Certainly in Britain, we see this across Europe. Few things are more worrying to the public than teenage crime, teenage drug use, teenage alcohol use, etc., etc. We know that health risk behaviors, smoking, drinking, accidents, drug use, sexual risk behaviors, are all initiated in adolescence. So again, at a time of major development. And there's been a lot of topicality around issues about licensing, because that's when we start to say to young people, you can or you can't do all these things that we do as adults. And we can see dramatic differences between countries in all of those things. Now, as I said, adolescent brain development, hugely topical. Jay showed some slides, and anywhere on the web you can see covers of Time magazine, a whole range of different magazines, Scientific American, particularly American magazines, but you can also see this across Europe. People fascinated by the adolescent brain. We see books. Look inside the secrets of the adolescent brain. Somehow people believe that this research done by Professor Geed and others will tell us the answers about why teenagers are so difficult and how we deal with them in a different way. Blame my brain is a classic one, in a sense. The idea that they can't help it, that we now have all the answers to adolescent behavior. But I think there's many responses, and I'll come back to that. So look, just to summarize in a sense, we've seen, and Jay spoke a lot about the development of abstract thinking, the development of planning and organizational capacities, and Deborah spoke about identity and behavior. And a lot of that comes from these areas of the frontal lobes, and particularly the medial prefrontal cortex, in terms of later development and organizational and planning activities. Colleagues of mine, Sarah Jane Blakemore and others, work particularly on the social brain, those ways in which we understand ourselves and we understand others. And we recognize that there's, in a sense, hyperactivity or differential activity of the social brain. And we know that there's a real vulnerability to peers. There's a heightened senses of embarrassment, guilt, and a whole range of social emotions that happen during adolescence. And this is, again, the medial prefrontal cortex and the anterior temporal cortex. Issues around sensation-seeking and appetitic drive, Jay mentioned briefly, and particularly Larry Steinberg's work, a psychologist, has focused on the way that young people have this appetitive drive, this need for sensation-seeking that peaks in middle adolescence, and seems to be linked to the dopaminergic striatal systems, and again linked to the medial prefrontal cortex. And others have looked at threat perception and the way that young people misperceive, make mistakes in the perceptions of faces and social situations as being more threatening than children and adults do, and changes in the amygdala. And these are just some of the changes, but perhaps some of the key changes that we see across the brain. And these changes, we hope or we feel, and this is the issue, do they drive these changes in identity that Deborah spoke about? Do they drive these changes in behavior that Deborah spoke about? And do they drive these changes in social relationships that we see very dramatically, not just in humans, but in other mammals? And that's one of the issues, is about whether we can attribute causality to this in terms of what we do. Whether we attribute causality or not, one of the most important things both Deborah and Jay said was about plasticity. The fact that these things are not deterministic for the individual and that we can see dramatic changes between them, but that adolescents can change. Okay. Now, Jay mentioned the way people take these arguments, and there's, in this sense, a number of ways they take them. If you say adolescents have an immature brain, the first response, which is a very common one, is to say we need to control them more. Young people are not responsible. We already knew that. We knew they're difficult. We now have an explanation for this. We therefore use the biology to reinforce our desire to control adolescence. So we increase the age of licensing, we increase the control over young people, and we say that this supports our beliefs that young people cannot be responsible to say yes to sex or drugs or a range of things. We should just say no. So it's a very ideological use of neuroscience. And of course, as we know from all science, the same science is used by people with a different set of beliefs to say an immature brain means of course they can't help it. That we actually should just let young people be young people. Their brain's immature. There's no way they can control themselves. They should experiment, and we should accept that. So this is the permissive view. They actually can't help it. And what's very clear, and we see this all through science, and in fact, this is classic sociology of science. We take science and we use it to reinforce our own beliefs. We rarely take our beliefs from science. So it's a very classic use of scientific discoveries. Other people try and take a position somewhere between, which is to say that there are certain areas of immaturity that make young people vulnerable to particular behaviours, that we need to think carefully about how we balance control and permissiveness to protect young people. Much more difficult in a sense. Now, Bob Blum, who's a professor from Hopkins, and Jay wrote an important paper back in 2009 about the dangers of taking neuroscience and putting it into policy. And largely, they said, in a sense what I've said just now, the dangers relating to assuming causality, assuming that these amazing things that Jay talked about therefore explain the behaviours Deborah talked about, that we can assume one is causal for the other. We know they're associated, but we don't know that they're causal. And a second thing is people focus on the deficits. They focus on immaturity, on a lack of control, and the issue about whether we need to control young people more. I think the question is, can we use this neuroscience? Can we think about it in a different way to maybe take something out of it that isn't about over-control or permissiveness, but allows us to get a sense of whether our clinical interventions or our public health interventions with young people are sensible. So not to focus on causality, but to actually look at where we are. Now, one of the classic responses in public health sense has been around graduated driving. Now, this, of course, is Wile E. Coyote. The reason I put this up here, of course, is that he is driving, not with someone else in the car, but he's linked with, I can call him a peer, the roadrunner. And there's something about the roadrunner's behavior that makes Wile E. Coyote absolutely mad when he's driving. And we know from Larry Steinberg's work and others that there's something about having other young people in a car that dramatically increase the riskiness of driving by adolescent drivers. So particularly in a number of states in the US, my colleagues will know more about this than I do, but we also see this in some parts of Australia and others, the idea of graduated licensing, which is that when young people are licensed, they are licensed not to drive with other young people in the car until they're substantially older. And there are other controls about how many people they drive with, whether they drive at night, etc., etc. And as they age, the gradations are they are given more and more responsibility. Very interesting paper in JAMA published earlier this year, I think, shows that this actually appears to reduce, I should say, accidents in 16 and 17-year-olds, but may increase accidents in 18-year-olds. So it suggests that there is a lot of promise in graduated driving. And the graduated driving is about particularly driving with peers, which potentially relates very well to what Larry Steinberg, Jay, and others have shown around the vulnerability of young people to peers when driving. The success of this, to some extent, has meant there's a real question. Should we take graduated licensing and apply it potentially to other areas of behaviour? Alcohol's the classic one that gets debated in Britain, but there may be others. Of course, you can't do graduated licensing for sex, because that kind of has to be social in a basic sense. There's also issues about health promotion and how we promote healthy behaviours within this, but I might come back to that. But in the most basic sense, my take on much of the neuroscience is that it reinforces what we know. It reinforces the fact that young people are different, that when paediatricians, child and adolescent psychiatrists, and other health professionals work with young people, there needs to be a set of developmentally appropriate communication strategies that change during adolescence. So we don't communicate with them in the same way as we do with children, or the same way we do with adults. Now that's very basic in a sense, but it fits hugely with what we know. So it's about training. Really first important response. Other responses. The issue about the immaturity or the late development of abstract thinking, particularly in terms of organisation and planning. And perhaps that allows us to understand risky behaviours better. But we have this dilemma about whether we should be more in control mode or more in permissive mode. And I think there are interesting areas in which we can actually try and get that right better. This issue about vulnerability in the social brain, I think is very interesting. We know that guilt and embarrassment, these social emotions, are far more tortuous for adolescents. They feel them far more strongly than we do later. Now, whether that's actually an effect of differential activation in the brain, probably related to puberty, which is some research that we're doing, or whether it's just we get used to how we handle these emotions is unclear. But this vulnerability to peers, which we can see with driving, suggests, firstly, that much of our work around peer mentoring, around group work, and others, which are basic clinical activities, both within clinical medicine, but also within some of the more public health responses, there's a basis for that. It's not new, but again, it supports what we do in terms of peer schemes. The other issue is that, we know this certainly, Deborah and I do a lot of work in diabetes. We often plan for failure. When young people are in hospital with us, we're working on their diabetes control, we really get things going well. We often plan with them. Actually, when you're out with their friends, we know things are going to go wrong. Actually, planning for failure, how are you going to cope with that? Let's think about your skills for doing with that. Actually, again, fits with this idea that young people have difficulty when they're with peers in a way we don't fully understand. I've mentioned the issue about sensation seeking and these issues about graduated licensing. Again, we can discuss whether that should go wider than driving. The issue about immature mentalizing, the immature understanding of others and self. Again, we need to think carefully about our communication strategies with young people, both in terms of public health promotion, but also in terms of clinical strategies. But some of the motivational work that's really sweeping through much of our clinical practice, actually I think has a basis here in trying to get young people to understand themselves better and understand their motivations better. So again, support for that. Just last, I suppose in a minor sense, this heightened threat perception. We know in a clinical sense that young people, adolescents, are often highly sensitive to professionals' faces. They often see a professional and hate them within the first 30 seconds of a clinical interaction. And this may be linked to their amygdala, or it may have nothing to do with it, but it actually fits very well. And again, it comes back to that idea of getting the communication style right and engaging properly. And classic medical interventions, busy doctor, not very happy seeing adolescents. Adolescents come in, the doctor's face tells the story. Young person doesn't engage, consultation doesn't go well, they go out. Again, we need to think carefully about how we use those sorts of things. And again, at the very basic level, and I think I've said this already, adolescence, the adolescent consultation is the only time in medicine that we communicate with somebody with a different brain. When we do pediatrics, adult brain, communicating, we play with the child, we learn to get the child's assent. But the decision-making is made by an adult brain communicating with an adult brain. Adult brain, adult brain. When we do adult medicine, adult brain communicates with adult brain. It is only in adolescence that our adult brain does not communicate with a brain that shares the same priority sets, that shares the same understanding of the world. And it is that reason why adolescence has to be a unique clinical consultation. All those issues around confidentiality, consent, communication style, foregone care, all of those things come directly out of that fact that we're not communicating directly with another adult brain. Now I'm going to leave it there because I think there's hopefully lots of time for discussion. And thank you.